Welcome to another PT Pearl. I'm Dr. Jen.
And I'm Dr. Dom.
So for today's PT Pearl, we're really going to dive into rotator cuff.
Yes, the old rotary cup. Have you ever had a patient come to you and be like, oh, I got a tear in my rotary cup? And I'm like, your rotator cuff? They're like, yeah, something like that.
Nope.
No, I guess that must be a small town Minnesota, Midwest Minnesota thing.
Anyways, we want to dive into what is the rotator cuff. Like, what does that even mean when people say you have a strain in your rotator cuff? Why is it so commonly diagnosed? Mm-hmm. What does that mean if it's diagnosed?
Some of the different diagnoses you'll get with it, whether it's a strain or impingement or tear or tendinosis, tendinopathy, all these different names and words that we use to label this rotator cuff pain.
A couple studies on the prevalence of rotator cuff and how often it's diagnosed and what it means and how you might be walking around with a rotator cuff strain or minor tear and you might not even know it. So a lot of what we like to talk about, Dom and I, we really go into, how overdiagnosed things are sometimes and why we cannot just rely on a diagnosis to determine the pain. Because if we want to dive into some of those studies like right away, I mean, a lot of people get diagnosed or a lot of people can have that rotator cuff strain or tear or minor tear, obviously not a full tear, but a minor tear and not even know it. Or they might have that tendinitis within one of the rotator cuff muscles and again, not even know it. And so all of a sudden, if we're just going to say, oh, now I have a pain and now I'm only going to contribute it to that diagnosis, well, it might be yes. And what else do we need to pay attention to? So we want to go into just bringing awareness to what it is, and then providing you with some tools that you can use within your own body to start seeing how we can kind of manipulate the body and why we don't need to just focus on individual muscles.
The studies that I was looking at mainly, and kind of what you were getting at, is how we in Western medicine and in American medicine we're so good and so smart with images and with tests at knowing exactly what's going on as far as the numbers or as far as what the tissue looks like. And that's makes it very tempting to then, once we figure that out, be like, oh, there it is. That's why I have the pain. That's why my shoulders hurt. And in reality, that's just the end manifestation of the real reasons that your shoulder's hurting, And so some of the studies I looked at, especially past age 50. So of course these were on older populations, but 20 to 25% of people can be walking around with a partial tear or up to a full thickness tear.
That's crazy.
And be asymptomatic. And up to 2/3 of the rotator cuff tears they found were asymptomatic. And some of the populations were done on asymptomatic people, meaning they had no shoulder pain. And it was still almost 20% people registered with some sort of rotator cuff tear, which is crazy to me. But then I also, if I can go into a little tangent, when we talk about imaging and a muscle and an MRI, when we image a muscle on an MRI, imagine one of those thick ropes that has about 1,000 little threads in it, right? And if we just nick and cut about 10 of those 1,000 threads, so very minor disruption in that rope, that would register as a partial tear in MRI imaging because it's a disruption and it'll cause that interference. So that's also where we have to understand what some of these positive findings on MRIs are showing and how minor they may be. So a lot of people will have these tears. A lot of them will be asymptomatic. So that doesn't necessarily mean that it is the tear causing the pain.
And when it comes to what is the rotator cuff, so let's cover that for a hot second. In PT school usually, or anyone studying anatomy or anything, we say the sits muscles. So we have our supraspinatus, and that is the most popular one that usually when talking about tendinitis or impingement or a lot of the tendinosis, so meaning that it's not like an itis, it's not an acute inflammation, it's kind of a longer term inflammation within the tendon. So it's been overused and kind of built that inflammation for a chronic period of time now. And when we say chronic, that's usually over 3 months.
Yeah, and what Jen's kind of touching on is when you say tendinitis versus tendinosis. Itis, when you hear that tendinitis ending, means it's like acute or a short term, or this has been happening for just a short amount of time and it's warm and it's swollen, versus osis, longer amount of time, not as much warmth and swelling necessarily, but still have that achiness that will come with a tendinosis type diagnosis.
Yeah. So the supraspinatus kind of is at the very top, and it's a small muscle here. So it kind of is just right at the top of the shoulder, but it comes down to the tip. So this top bone that we can kind of grab right here is actually part of our shoulder blade. It makes up, like, think of the ball and socket within the shoulder. It's going to be the top portion right up here. Okay. So that bone that floats up and over on that shoulder blade area, this is what we can grab right over here. And then that's going to connect over into our collarbone, stuff like that. Okay. But now when I move my shoulder up, that is the head of my humerus right here is going to move up and along, and we want our shoulder blade to hopefully be moving out of the way so that we have full range of motion. But if we don't have full range of motion and something's getting caught and stuck, you can see how if a tendon or the portion of that muscle, that tendon from that muscle is running underneath this bone here from that shoulder blade and on top of my humeral head here, then if I don't move my shoulder blade out of the way, I can get that pinching. So the pinching over and over and over and over again is what can cause that acute or chronic inflammation, that irritation, that sense to our nervous system and to our brain and saying pain,
ouch,
alert.
Ouch. And that's where with rotator cuff impingement symptoms, one of the common things we see is what we call painful arc, which is at about 90 degrees, because our humerus, like Jen was saying, our arm bone gets up to 90 degrees on its own pretty easily, and we have plenty of space to do that. Even if we're sitting with bad posture, 90 degrees, check, right? If I try going up above 90 degrees with bad posture without moving my shoulder blade, I start getting some pressure in the front sides of my shoulders. It's once I move my thoracic spine and shoulder blade and let that shoulder blade rotate out and clear that I can get above head without having that pinching. So that's where you'll get that painful arc, because we might not have that space you're talking about.
Yeah. Then we also have subscapularis, and if you reach underneath your armpit and kind of grab your shoulder blade on the inside, don't pinch too hard. Where we have arteries and nerves and all that run out of there. So if you might notice, like, my hand is going numb, so don't grab too hard. We need to be careful, especially when you're unsure of what you're grabbing there. But basically, the subscapularis is on the inside of that shoulder blade. So my shoulder blade's on the back, right? So it's going to be on the inside, and this is really our internal rotation muscle. So it's going to take this arm from the outside and rotate it in. The other one, which mine likes to flare up quite a bit, is the infraspinatus.
A lot of people have real hot infraspinatuses. I feel like that's a real popular one especially if you sit at desks a lot, especially if you have that kind of internally rotated, or if you do a lot of weightlifting. Anybody who's into some heavier CrossFit or that type of weightlifting, I find has really hot infraspinatuses.
So that's on the back of that shoulder blade.
And that does more of your external rotation of the arm.
And the reason, especially if you're stuck in an internally rotated position working on a computer and kind of have your arms kind of coming in, now imagine this arm that really wants to pull you out and open is now being forced internally. So it's almost working on like a pulling, stretched type motion, and that's why it gets so hot and heavy. So think of it like elongated, but still trying to hold you up and hold you into place. So that is why that back of that shoulder blade, you touch it and it's like, ooh, that really doesn't feel so good. And that's why we usually like to say, okay, what kind of mechanisms can we bring in where we kind of take pressure off of that shoulder blade?
And that guy's kind of paired with your fourth rotator cuff muscle, which is the teres minor, who kind of runs along the similar path right from the outside and the bottom corner of that shoulder blade all the way up the arm, and also does kind of that external rotation moment. In
general, the rotator cuff and why it's so important and why we do these internal external motions, now you can see why these are probably prescribed a lot, is because it literally does internal rotation and external rotation. Those are the main forces. But the main reason that the rotator cuff is talked about so much and why we like to bring attention to it and pay attention to it is because the rotator cuff is literally what is holding your shoulder in the socket, because we don't have like ligaments and tendons that come underneath the shoulder, but we don't have anything underneath. So our shoulder would fall out of the socket if we didn't have strong and stable rotator cuff muscles. So they literally contribute to the stability within the shoulder. They get hot, they get heavy. If you're in a hunched position, your arm is only going to move so much. So if we're like, okay, you have rotator cuff syndrome and we're only going to give you internal, external type exercises, we're only going to address the stability of that shoulder and say, let's build on that stability.
I sit there and do manual work or tissue work on your shoulder all day long to get those symptoms to go away.
Yeah.
Similar to you saying doing exercises, internal, external rotation at the shoulder.
Yeah.
I think you're getting to the point that we need to do more.
Yes, 100%. And that's where we have to then look at like, okay, how do we get that shoulder out of that painful position? And that's where we look at the thoracic spine, because we can literally change your shoulder range of motion and those impingement syndromes or symptoms just by taking that thoracic, that upper spine portion, and having it upright. Literally, when we move it into a more extended position, we move the rib cage on top of that. So remember that our rib cage is connected to the thoracic spine. If I adapt and move my thoracic spine, I move that rib cage. Now, when I move that rib cage, I have freedom for my shoulder blade to move. And that is the whole point. Like if my shoulder blade doesn't move, then I'm gonna get more pinching into my shoulder area. I'm gonna make my rotator cuff work overload because it's trying to do all of it then, rather than utilizing my thoracic spine, utilizing my shoulder blade, utilizing more bigger muscle groups rather than just these small, tiny ones.
Well, no, and that's what I find the most is what causes a lot of these imbalances. I mean, yeah, the rotator cuff does the internal, external rotation, and our supraspinatus helps us elevate our arm, but it is more that stabilizer, and it's more active when we're doing really, really light loads, which is why you have this big shoulder pain. And say you're somebody who is very active or does CrossFit or does some heavy overhead lifts, and you get these tiny little wimpy exercises and you're like, what is this? I lift hundreds of pounds. How is this going to help fix my shoulder? In reality, it is those other shoulder muscles taking over and just making that ball migrate in the socket because our rotator cuff can't handle it. That's what causes overload and strain.
So it's not just about working external rotation. That's great. But again, we might overwork external rotation. So how can I first address what's pulling it forward? And that's where, kind of getting into positions that will allow the pec to relax a little bit more, allow the pec to not do so much work, make sure that you're utilizing the punching muscle, your serratus anterior, rather than just relying on the pec to do a lot of motions. This can be overwhelming to hear because it truly is like, then now not just looking at the pec and other muscles that might be overworking and overloading, your upper traps. Upper traps. And that could be even just how you're like sitting at work all day and allowing your shoulders to come up to your ears because you're getting so stressed out. And then you go to the gym and then the only thing that knows how to activate is your upper trap. And then lats can take over, and some of these other muscles that want to help with it. We're not anti working the rotator cuff. We definitely think that it's important, and it's something that going back to those little stabilizing exercises help, but you also get to address where my movement imbalances might be, what might be overtaking, what might not be moving well. So the thoracic spine, the rib cage, the shoulder blade, and how we can address the system as a whole rather than just looking at that inflamed supraspinatus. One of my favorite, I'm going to give one of my favorite exercises.
Do it.
And then you can give one of your favorite exercises.
All right, see if I can think of anything.
But one of the favorite things that I like to do just to like maintain so that we're not going into pain is actually addressing that thoracic spine. So every morning before you get out of bed, do what is called an open book, which you can find on my Instagram, DocJenFit, everywhere, because I do it all the time. But literally just laying on one side, you reach forward and then you bring that shoulder blade back and you reach and you open back. So it's laying on your side, keeping your knees over to one side and only moving from the upper back. And you do some breathing with that, some slow relaxing, and you just get that upper spine to mobilize, because when we mobilize into rotation, we're actually helping with extension as well. So it's not just how do I pull my shoulder blades down and back more, but it's how do I rotate more? How do I move throughout the spine so that I can get it to open up? So just like we were talking about earlier, from even just really changing the way that we move in our thoracic spine, it helps to open up the shoulder so much more. So even just thinking about opening up your thoracic spine and your upper back can help to change the way that you feel in your shoulder.
I love that, and I love the open book, and it's definitely one that I get to work on more and more for my own shoulders. I think I'm going to take a little bit of a cheater's route on my one favorite exercise today, because especially, and this is especially for people who spend long periods of time either sitting for work, or if your job keeps you in the same position for a long time. And if we're in a sustained or stagnant position for a long time, I like to talk about my one rule or one exercise being the 30 for 30 rule, which is every 30 minutes at work, especially while you're sitting down, hammering away at work, for 30 seconds should move into the opposite position. So if you are sitting in this kind of internally rotated, hunched over position, and every 30 minutes we take time to get up, open up those shoulders, pinch them down and back, get those arms moving. I don't even want it to be anything specific, because I think we get too attached to what specifically I should do. What you specifically should do is move.
Yeah,
and
exactly.
You specifically should not sit in one position for more than 2-3 hours or more than 30 minutes. And if we do that every 30 minutes, then you're getting up 10, 12, 16 times throughout work, moving your blood, moving your lymph, moving your brain fluids and juices, and actually probably being more productive at work. I think there are studies that back that too. Nothing that I specifically looked into, but keep moving your body. So 30 for 30 rule.
Rather than finding the one optimal position, which kind of goes back to the whole point of our podcast, there's no one perfect thing. It's finding something different. So how are you going to move your body to do something different? That's it. So it's like exactly like you said, you be here, open up, do something different.
Regardless of what we say or what the biggest guru in exercise says and how they cue, you need to do it based on how it feels and how you feel doing it. It's like the most intelligent or best mover in the world can cue you a certain way and tell you should feel something, and it could feel way different than they expect.
Every different type of stimulation that we do for movement internally and how we're feeling it externally is all going to help to better map our brain. So think of our brain as maps to our entire body, right? So our brain has really good maps to certain parts. So like our hands, we can detect things without looking at it, right? By just knowing what it feels like in our hands. Our feet are pretty good too, sometimes, some more than others. But there's different parts in our body where it doesn't have as good a feedback. There's not great mapping. Like think of our stomach, think of our torso. Like who touches it enough? Like maybe you get back rubs, but is anyone doing stomach rubs? Or even the shoulder, like you're aware of it, but is anyone touching it? Have you rolled on it lately? Have you done different things? So even just bringing awareness through movement and externally helps to better map the brain. So hopefully you got just like a good idea of a better way to approach a shoulder and think about rotator cuff, not be so scared of it. It's a high prevalence and some people don't even feel the pain if they have the diagnosis. So it's not something to fear. It's just something to work with. Okay, what am I not doing enough of? What am I not moving into differently? What am I, and just start to explore the entire body as a whole.
Hey, what's up, everyone? Thank you so much for sticking around for our PT Pearl. We love doing these things to bring you little tidbits about the body that can help you move into your optimal body. Please, if you have any questions or comments or thought it was great or thought we could do things better or have topics that you want us to do, comment below. Subscribe, reach out to us, like it all, and we will keep bringing you these PT Pearls to help find what optimal means
within your own body.